Hello and welcome to Greiner Bio-One Talks. My name is Anna-Maria Šimundić and I am a Global Director of Medical and Clinical Affairs Department at Greiner Bio-One. And we are here today to talk about sustainability in Preanalytics. And I have an immense pleasure to welcome my guest, Mads Nybo. Mads, welcome.
Thank you.
Mads comes from Denmark, Odense in Denmark, where he is the head of 2 laboratories at the Odense University. He's also a chair of the Danish Society for Clinical Biochemistry. He's also a chair of the Nordic Working Group on Preanalytics and is also expert consultant of EFLM Working Group on Preanalytics. So obviously, Mads, you have a huge experience and a lot of a long career in Preanalytics. And you're also working in a hospital that is highly concerned and motivated to address sustainability as a topic. So I think you're a well-fit for this interview.
Could be, yeah.
Thank you for accepting my invitation. So when you think about sustainability in Preanalytics, what comes to your mind when you hear those words?
Well, first, the word sustainability is very much on the agenda. I could say not only on the health agenda, but also in the public agenda and the political agenda. So I think that's very hot topic, so to speak. And then when you say Preanalytics, I tend to say what? But when you think about it, there's a lot of things we probably could do. So I think the coupling is getting more and more logical. But from the beginning, it's been kind of perhaps the sustainability was something with industry or something else. But when you look at us as a health industry, we actually can do a lot within sustainability. So I think it's rising from not just a public demand, but a logical demand to something that actually is perhaps not feasible, but doable, and we should do something about it. So I think it's growing on me. That's what I'm trying to say.
And it's a shared responsibility. So it's not only the industry, but also on the laboratory side, there is a lot that can be done.
I mean, as I tend to say, we are sitting in the middle of the machinery. So if we can come up with some ideas that we could give to politicians or to industry, that's our obligation. Because when you see things from the outside, it's not always possible for you to say, we could do this and that. So I think it is our obligation as laboratory professionalists to come with good ideas and suggestions for how we could make things more sustainable, for sure.
So where in pre-analytical phase do you see major room for implementing some sustainable solutions? Or where do you see the gaps or needs?
Well, so I would say we haven't looked on Preanalytics from a sustainable point of view before. So I think there are possibilities all over the line, so to speak. So that's all from, requesting less tests, so what we call demand management, to perhaps drawing less blood, using tubes that do not have so much carbon footprint, transport them in more less energy consuming way, and then of course also look into all what we do when we receive the samples, and then the analysis, of course. So I think the entire line for the laboratory is to look into from a sustainable point of view, because we have tended to look on it on a more productive, flow-oriented, speed fashion way. And now this is a different pair of glasses we need to take on. So I think we have to start all over, actually. And I think there's possibilities all the way.
Yeah, absolutely agree. So, what is the state of the art? Where are we now when thinking about, the room for improvement? Is if you think about your lab, is the sustainability solutions that you would implement, is that something that you would do on a voluntary basis? Or are there some regulatory requirements, legal requirements? Is somebody demanding that? Or is it just something that you would do because you believe that?
So to my knowledge, we don't have any legal demands in Denmark, but we do for certain have a kind of a public pressure an expectation that we should do something. And I think that goes for all of us, that not just for the laboratories or the hospitals, but for all of us. So I think there is an expectation, and I would also say at our hospital and in our region, that's 2 million inhabitants, so it's small regions, but there actually is an agenda, a green agenda, where I'm actually the lead for the laboratory agenda on the green side in the region. So there is an expectation. We have regular meetings every month, coming up with ideas and making projects that we can align. So for certain there is an expectation from the hospital, but inside my laboratory, I think we are talking about it, but I don't think the ideas come so often from everybody, so to speak. I often think perhaps I must be the one to introduce them, but I really think there is a tremendous willingness to use them, because everybody knows the agenda. So I think there is the political agenda, but again also, as we talked about, new generations thinking about there's no planet B and all these things. So we have to do something, and everybody feels that. So coming up with ideas that can save energy or consume less, everybody's happy to do that. So I think there's no opposition against it, but sometimes the ideas are lacking. So I come up with some, and that's okay. So.
It's difficult actually to address it in a systematic way. It's almost like we are missing the framework, right? To address it in a systematic way. We know that it needs to be done, but maybe there needs to be a kind of a framework, like a long-term plan, how to do it.
That's right. On the other way, I would say that the EFLM Green Labs paper actually lays out quite a solid document, you can say, with a lot of points you can go through and actually start from A and go to C. And I think that's a good way to go, because then you are sure you are covering all the bases. On the other hand, it's a very, very long document, and I think people tend to get a bit frustrated. So I think you have to cherry pick a bit and say, okay, could we do something in this area, and can we do something here? And then we wait with the rest. Or you have to see, where can I save most energy and do best sustainability-wise, and then do that. So I think we could cherry pick the one where we gain most and then wait for the rest. What we're trying to do in the region, actually, we're trying to do different things. So the laboratory, one place doing this, and we're doing something else, and they say, okay, that was a bad idea, but that was a good idea, so we can copycat it. So we kind of do an internal experiment, so to speak, and then we can work through a lot of the subjects together. So I think you're right. There's not a goal line, but there is a document that can help us, and I think we just need to get started.
Yeah. So you were just saying, there are different labs trying out different solutions. So could you share with us maybe some solutions that you think are maybe already successful in addressing sustainability as a topic?
So, for example, we have the small lab I'm responsible for. They have been transporting most of their samples by bicycle, coming from in town. So instead of driving around in cars, having difficulties finding parking places and so on, actually they have an electric bike where they have, a hood that has room for the samples, and it's refrigerated, so they are kept at the temperature it should be. And then they can go around, pick up samples from the GPs, from the general practitioners. So that's a small thing, but I think people think it's funny, and they think it's easier to find parking spots. And then also they actually save the environment for some energy carbon print. So I think that's a very good thing. You can use that if you have to go for 100 kilometers, but you can do it in smaller settings inside cities. So I think that could be useful in many big cities, because it makes it easier and a bit more funny, perhaps.
Absolutely.
If it's the traffic safe, of course.
Yeah.
So I think, and we're going to use that also in Odense, a bit bigger city, but we could do the same. So I think that will spread out to many cities, actually. We ourselves have done a lot about looking into the freezer temperatures. So we actually increased that from being -80 to -70. And we know from other papers that you actually save, I think it's 20 to 25% of the energy just raising the temperature of these 10 degrees. So that makes a lot of sense, actually, doing that. It gives a lot of discussions with researchers and regulatory bodies. Is this safe? But the point is that the -80 has never been safe. It was just a choice. We took because
arbitrary value.
And it was the freezers could do that. So this is what we do. If it could do 90, you've done that. So I think we are capable of going a bit back, and we have to defend ourselves, but we must do that. And now we have the environmental sustainability agenda. to do it with. So I think this is a good idea, and we've done that for most of our freezers in Odense. We have some national biobanking, where the biobanking institutes still are a bit dodgy about this, so we have not done that there yet, but I hope within a few years we can convince them that should be done for all biobanking as well. So I think we are going down the right path in many directions, and this will also spread. Now we're doing this in Odense. I hope we can do it in the rest of the region within next half year, and then that can spread out. So,
Well, you were mentioning the demand management and also the blood collection tubes and volumes of tubes, but also number of tubes. Could you comment on that? Did you already try to address that?
Yes, so when you're looking at the waste hierarchy, you would always like to start in the top, and that's do less. And that would here be to reduce the number of tubes. And what we have been doing for quite some years, also as recommended by the FLM working groups, has been to look into the demand management concept of trying to persuade people not to over sample the patients, so to speak. We have introduced a lot of pop-ups electronically. So when you request samples where you do have a value within what we call the minimal retesting interval, that could be 4 weeks for HbA1c, then you can't repeat it. So you're kind of blocked, actually. And that's given a lot of irritation. But due to this agenda, actually, people can say, okay, it makes sense because we help saving the environment, so to speak, and be more sustainable by not doing unnecessary testing, of course. So I think we've done quite some work on that. We're trying to attack it scientifically. We've tried to educate general practitioners and done different approaches and tried to see which approaches actually works best. Is it education? It is IT blocking? Is it being rude? Is it being nice? And of course, it turns out to be a variation of all of it. Yes, of course. And then it only takes place, or it works for perhaps a year, and then you have to start all over again. But well, that's our full-time job for now. So I think we are working on this, and what we've just seen is that just came a new recommendation for osteoporosis, for example, a guideline for how to diagnose patients with this. And we already now, as a guideline is coming, are putting up some of these blockers or pop-ups because we know some of these expensive analyses will be overused and they shouldn't be. So I think we have been a bit behind, but now actually we are trying to get in front of the race. And I think we have succeeded in many of the aspects. So I think we're in a good spot. The latter, I would say, have succeeded because actually, as being chair of the Danish Society, I have talking to the other societies, including the Society of General Practitioners, saying, you have to let us in here. You have to talk to us about these recommendations when they're coming out or before they're coming out, so we can help doing it in the right way. And I think they've gone from being a little annoyed to see, okay, it makes sense, actually. So again, I think the sustainability agenda actually helps us.
Absolutely. And what about the number of blood tubes and the volume of blood tubes? How did you address that?
Yes, so what we actually did quite rude was I saw a Canadian study actually on how you could reduce all tubes to a smaller size if you really didn't have to have a lot blood for a lot of testing. And we did that almost overnight at the hospital and could see that we actually could reduce sample size from 10 or 8 or 7 or 5 mil to perhaps 2 or even less mil for most. And I think it was an eye-opener for many of our specialists that you don't have to have a lot of blood. We just end throwing it out because analysis today, we know that they use 10 microliters perhaps for measuring something. So what would you need 10 milliliters for? So I think also we have, how should I say this, forgot to follow up on how our instruments actually are performing much better. They don't have so much dead volume, they don't use so much material anymore, but we still draw the old sample volumes. So I think we have to take a chunk off and just go to the lowest possible volume, and I think that's a good way to go.
And it's also the ISO requirement. ISO requires you to monitor and revise the volume of blood collected from a patient. So it's not only a matter of, I think I should do it. It's a must, right?
I think the problem with the ISO now, I'm being an ISO assessor myself for almost 15 years, and I think the problem is we read it once a year when the ISO assessor shows up, but we don't really think about the thoughts behind it. So if we did that, I think we could have a lot of help also, because it is kind of a accreditation law text we have to oblige to. But I think we see it as something a bit annoying when these people shows up once a year. If we instead could see it as a help and also as a tool to say, but we have to do this. I think it would be better, but I can fully understand also, see at my own lab, it's kind of a bit annoying, but we could help each other to take it seriously, perhaps. So, for sure.
So it was interesting, you said you did it in a very brave way, almost overnight. So how did you make sure that you don't, that you have enough sample volume of the sample?
So...
And that you not compromise the
well, I say the latter, I don't think we did. But for the first, I would say, this one with making omelette and cracking eggs, sometimes you have to do something and find out, okay, that was a bit, you were missing something, and you have to retract or redo something. So, of course, there were some instances where we found out, okay, that was perhaps a bit too much. But I think I'd rather do this and then go a bit back than not doing anything at all.
Exactly.
So I think it was a good way of approaching a solution where we didn't know the answer, and then finding out how to do it. I think you normally say, if you treat patients with hypertension, you give them a lot of drugs, and then when they pass out, you're giving too much, and then you go a little down in dose. I think it's the same here. You have sometimes to do it, but of course not endangering patient safety. I don't think we ever do that. But I think we have a dialogue with our colleagues, the clinicians, intensive care patients. We wouldn't dare to touch before we had a dialogue with them, knowing that they are well off. But much of the sampling is mostly in our hands, and dealing with, something we agreed upon 10, 15 years ago. So it's not up to date.
And what was the feedback of the clinical staff, nurses and clinicians?
I think in general, I think they thought, why haven't you done that before? I don't think they were surprised or irritated. I just think they thought, but you're in charge of this. Actually, some years ago, we did that. We have some arguments with our pediatricians, how much blood we could draw from children, and I made an algorithm. So when you are drawing blood from them, we actually accumulate how much blood have you drawn from the child. So we know we're not drawing too much. And they were actually quite surprised how much we drew. So when you come and say, okay, we can't draw any more today because we are up to 10% of body weight, they were kind of, what? But then we have then we shouldn't do this and this and that.
Yeah.
Okay, that's a good way to do it. So I think doing these counting volumes actually helps us have a good dialogue with them. So I think there are some areas where we need some more firm data to convince them, and that perhaps will be the pediatric and the intensive care areas. But otherwise, I think we are in a good position, and the clinicians are very interested in doing this.
So what are the volumes of the tubes that you are now using?
Oh, I think we are down to 1.8 for most of them, actually. And then we do have when they come to, that could be in general, for example, our infectious diseases, where they have to measure a lot of different antibodies. And that's a bit out of our hands, because many of the antibody measurements is not at my department, that's in the clinical immunology. So, and they are still a big... they are not. They haven't been so fresh in renewing their volume. So I think we are still looking forward to do this also on the other laboratory specialties, immunology and microbiology especially.
But that is really impressive. I mean, if you started with, you were saying 6 ml, 7, 8 ml, it's like almost four times decrease in the volume of the blood. That is really amazing.
Of course,
result.
what we're missing is perhaps still, as you say, some of them should perhaps have drawn more, so we are sure. And there we have to perhaps have some more ward-specific things, but we're working on that right now. We've just been a bit, brute force, and then we're moving forward, and I think it's been good, actually. So.
Have you noticed maybe, because you implemented low-volume tubes, did you notice the reduction of hemolysis in patients?
No, we didn't. And what we actually talked about, it could be interesting to look whether we had fewer patients with anemia, because we know that some of these phlebotomy-induced anemia where we draw too much. Yeah. But we haven't looked into that, not to hemolysis either. I mean, we are doing hemolysis indices on all the samples, so we could do that. But that could be an interesting idea, perhaps. Yeah.
Okay. So let's now move to waste. And obviously, labs create a lot of waste. And tubes, blood collection tubes, are maybe the major contribution to the waste that lab create. So how do you currently handle the waste in your lab? What is how much are you aware of that? Did you think about it? Is it a substantial cost? Do you have any thoughts about how to reduce that? How to tackle that issue?
Yeah. So we do have waste sorting already. So we are sorting all plastic from all the reagents and things. We have wrappings that's sorted, and not at this hospital, but in the new hospital we're building, where we should move in 2 to 3 years. So actually going to be a plastic decompressor where all plastic is delivered and being compressed and then delivered. So we are handling that centralized actually. So for now we are just sorting it, but that's one solution that we are already working at. Also, we are gathering all the polystyrene, flamingo and boxes, and we are actually shredding them so they are compressed, and so they don't fill that much. And actually, this material can be used for isolation in the building industry. So before, where we paid a lot and then transported and incinerated, now we actually earn a bit on it for isolation material. So I think that's quite a funny story to turn over something that could be harmful for the environment to actually increase sustainability and also help building industry. So we always look into whether we use too much of things and try to reduce them. That goes for reagents and controls and everything. But I think, as you mentioned, the greatest obstacle we have is our blood samples, because there are so many, and they are biohazardous waste. It's expensive to get rid of, and people are kind of worried that you can spread diseases. So they are very careful. They are wrapped in bags and incinerated, and that's it. So they're difficult to approach, you can say.
So would it be possible then to think about ways to make the tubes circular? So to kind of recycle the tubes and have them been used again?
Yeah, so I think what's important is that in terms of biohazardous waste, it's difficult to clean them and reuse them one-to-one. But I think you can recycle them. So I think it's important to distinguish between those two things and say you can probably not reuse them as they were, but you can recycle them. So if you can get rid of the blood and you can get rid of the label, then you can actually melt them and use them again. And what we would very much like to see was perhaps could they be used to new blood tubes. Downcycling would be okay, which means you could use them for other cheaper kinds of plastic. But I think that we'd be very happy if we could maintain the high quality production of PET plastic tubes we have today. And what I've learned is that if you have a normal plastic cup, the plastic type is reusable 7 to 10 times, then it kind of falls apart. But these PET tubes, this plastic is so high quality, so we're talking about perhaps 100 times they can reuse. So it's a very high quality. That's actually really a shame. We're just incinerating. So answer to your question, yes, we should do something, and we are trying to look into with a project how we can actually do it, showing that it's possible to go from biohazardous waste to just waste. And the next step is hopefully that we can prove that it's also possible to go from waste to recycling. And for this, we of course needs the industry, the manufacturers to enter in partnerships, to be interested in this, because otherwise we can't do anything. What I think on top of the sustainability agenda is the scarcity of materials we are seeing with wars going on in the world, unfortunately, where we've tend to find out that perhaps we have to be self-consuming. We have to have our things ourselves. So if we can reuse the plastic, we don't need plastic from abroad. That could be US or China even. So I think this also means that you in Europe actually could manage to have your own materials and keep them going. And I think that's very important, also part of the agenda.
Yeah, that's also actually being sustainable, right? Yeah, to rely on your own energy resources. Yeah, exactly. So you were saying the industry also has a role in that. And obviously, if this process is to be implemented, this recycling, it has a cost to it. There is a cost to it. So what do you think about it? Would you as a lab manager, or would a hospital be willing to pay for not only the circular tube but for all sustainable solutions? Is there a will to pay more for more sustainable solutions? What is your opinion?
Yeah, so as I said in the beginning, I think there is a clear political agenda going towards sustainability, and that's for future generations to come, but also for the present. So how can we do this? And I think for certain that you will find politicians are willing to find economy to put into a sustainability agenda. So that would be a yes for a start. The problem is that the healthcare system in itself gets more and more expensive every year because of increased costs of medicine and more elderly people and so on. So already now we see that it's an increasing cost at the hospital. So we should carve out a bit and say this is sustainability. And I think that could be a bit problematic, perhaps. Having said that, I think that also having the sustainability agenda local at our regions and at our hospitals gives a certainness that you should do something. We must do something. So if I come as a lab leader and say, I would like to carve something out from my budget to use on this, I think my manager will say, that's okay. You just have to find the money somewhere else because there's not more money in the pot necessarily. But I think that would be okay, because if I then could do savings, for example, by demand management or saying, okay, now I don't have to pay dearly for biohazardous waste because I reduced it to normal waste. So I could keep that in the same flow, so to speak. I think that would be okay. And I think the money would stretch far enough for doing that. So I think, of course, there's a break even where we can't find more money to do more solutions. But I think within the limits, I think we can get really far. So yes, I think people would be interested in paying for it. No, there would not be more money in the system, but I think we could create some economy for doing it if we are smart.
I really liked what you said. So you can, by what I think might be possible is by allowing waste to be used for recycling, you could actually reduce the cost of waste management. And this cost is quite high, especially for potentially biohazardous waste. So in the end, from the top of your head, what do you think, is there, would you as a lab be on a positive balance side when, if you would need to pay more for, let's say, green tube, but you would be able to reduce the costs of waste? Well, where do you think would be the balance, on which side?
Well, I mean, for start, I hope it could be equal, so the money saved can be the one I am using more on the green agenda, so to speak. And I think that would be fine. We are not here to earn money in the healthcare system we have in Denmark. We're just here to balance the economy, so to speak. We also want to stretch the economy as long as we can. But this is a good agenda. This is an important agenda, and there's a political highlight on it. So I think that would be no problem to do that. Having said that, again, of course, if everything costs 100 times more, there will be a limit for how far we can go. But I think for certainly we would be interested. And another thing, of course, that we would do was include in our tenders that we do, for example, have a regional or national tender to buy new tubes, saying, okay, it's a demand, they are recyclable, that there are places you can deliver the plastic, they are used and we can be guaranteed, so on and so forth. Of course, the price will be higher, but that will be part of the tender, I think, and that could also be part of the competition between the companies, of course. But I think that would be a good way to go, because then it's going to be applying pressure on all the implied, including the laboratories.
Yeah, absolutely. Well, thank you, Mads. And we are approaching the end of this podcast. I have just one last question. You have a very long career and a lot of interest in pre-analytics, and I'm sure you've throughout your career had the opportunity to solve many pre-analytical, so to say, mysteries. Is there something that you have encountered throughout your career that was really a memorable moment? Something that the challenge that you solved and that you know has made an impact on a patient or patient health?
Well, several, of course, but one that comes to mind is we actually have quite an obstacle with a child that was admitted where they measured blood glucose continuously, and it didn't move. They couldn't make it higher without, even though they gave a lot of glucose infusion, and we were very worried about this, and it ended up, I was a younger doctor back then. I went to the ward to see what was happening, and it actually turned out that all the glucose values were measured at their POCT instrument at the ward. And it turned out it wasn't a glucose measurement, it was a hemoglobin measurement. So they measured on the wrong instrument and measured the hemoglobin concentration, which didn't alter at all. And the glucose, when we measured that was 15 or something. So it wasn't low in glucose. Actually, it was going the other way, but they were measuring with the wrong instrument. And I can remember I was kind of puzzled. How could this even happen? The instruments they looked the same, but there was a word, it said hemoglobin and it said glucose, but they didn't see that. So I was very intrigued by the hastiness that's in the clinic, how urgent it is, how sick the patients are, how busy the nurses is, and the doctors, when they get some reports and numbers, they rely on these. They don't necessarily get skeptical. So when I'm teaching also at the wards, other doctors, I say, please be skeptical. If something doesn't fit with the patient, please think, could it be something wrong with the numbers? I know I'm a proud laboratory doctor, but still we do make mistakes, so please come to us and talk. And even if we talk about drawing performed at the ward or POCT measurements done out there, even worse, I would tend to say. But I think it was kind of an eye-opener for me that it's not bad blood, it's just busyness, and then we have to help them coming from the laboratories. So I tend to try to remember that when I go out there. They're doing their best, you're here to help. So I think that's important.
Yeah. So would you say that the role of laboratory professionals is to get out of the lab, to be present in clinical department and
for sure.
educate?
I mean, we just made a new strategy for our society where we have one keyword, that's cooperation. So you have to get out and do cooperation. That's with clinicians, that's with the patients, that's with the hospital, that's with companies, because staying inside the laboratory walls doesn't get us anywhere. It just makes us more, boxed in, not knowing what's happening actually. So if we're going to be if we're going to know what the obstacles are running a emergency department or drawing blood from children, you have to go there. So for sure, you can't be a laboratory doctor staying at the laboratory. You have to get out of the laboratory.
Break the silos and go out.
For sure, yeah.
Thank you, Mads. It's been really exciting to talk to you about this topic. And I really hope that you have enjoyed this podcast as much as I have.